Hello everyone. Welcome you all to Oral Medicine and Radiology Made Easy. Please like this video and subscribe to this channel. In this video, I'll be discussing about systematic interpretation of orthopantomograph or OPG. Why should we systematically interpret this radiograph? When compared to intraoral images, panoramic images are quite different and demand a disciplined and focused approach. Recognizing normal anatomic structures on panoramic radiographs is quite challenging because of the complex anatomy of midface, superimposition of various hard and soft structures, and changing projection orientation with real, double and ghost images, and also many potential artifacts associated with the machine and patient movement and patient positioning must be identified and understood. The points we need to remember is that unlike IOPA, it's a panoramic view. Multiple areas are covered in the same radiograph and multiple anatomic landmarks are visible, and also it portrays the complex maxillary structure. If you take a closer look at the OPG, we can see segments in the panoramic image. That is, it is composed of right and left lateral images connected in the middle by PA image. This is the lateral ceph image and here is another lateral ceph, and central part resembles a PA skull. So, OPG is a combination of right and left lateral images connected in the middle by a PA image. The main purpose of taking any radiograph is to diagnose the pathologies. But unless we are able to understand what is normal, we won't be able to diagnose the abnormal. So, a detailed knowledge of normal anatomical structures is necessary. Practitioners should avoid limiting their attention to one particular region of the film. Rather, all aspects of each image should be examined systematically. We need to learn to differentiate between normal anatomy, variations in normal anatomy, and pathosis. So, in order to start a systematic interpretation, we need to place the film on a illuminated view box. It's helpful to view the images as if looking at the patient, with the structures on the patient's right side positioned on the viewer's left. For a better interpretation, the OPG can be divided into 6 zones. Zone 1 comprises of the dentition. In an ideal radiograph, teeth should be separated and arranged with an upward curve posteriorly, producing a smile-like arrangement. Zone 2, nose and sinus. Here is the Zone 2. Inferior turbinate should be within the nasal fossa and hard palate shadows should be above the root apices. Zone 3 is mandibular body. That is, inferior cortex of the mandibular body should be smooth and uninterrupted. Zone 4. Condyles are centered in this zone and are equal in size and position. So, Zone 4 is present on either side of the OPG, which shows the TMJ. Zone 5 is also on either side of OPG and it shows ramus and spine region. The ramus should be equal in width bilaterally and spine should not be superimposed on ramus. Zone 6 shows the hyoid bone. So, these are the 6 zones to be identified in an OPG. Now, let us see how to interpret a panoramic radiograph. In my previous videos, I have shown what are the different hard tissue and soft tissue landmarks visible in an OPG. OPG has so many structures and it is so confusing. To overcome this, let us learn systematic interpretation. A systematic approach to viewing the radiographs is necessary to ensure that no relevant information is missed. This systematic approach should apply to the entire radiograph, also to specific lesions. Let us start with general overview of the entire image. Note the chronological and developmental age of the patient. Trace the outline of all the normal anatomical shadows and compare their shape and radiodensity. Interpretation should start with the mandible. Begin viewing the radiograph at the superior aspect of the head of the right mandibular condyle. Follow the posterior border of the condylar head down past the condylar neck along the posterior border. Move down towards the angle of the mandible. Carefully assess the outline of the border. Check how is the shape of the condyle. Is there any discontinuity at the neck of the condyle? Check if the cortical bone intact. Is the image of the cortical bone of equal width, or is it scalloped or expanded? Can you account for the radiolucent and radioopaque shadows superimposed over the border? So these are the features you need to check. Here you can see how the condylar shape has been changed. So as you come down towards the neck, you can see there is break in the continuity suggestive of fracture. You can also see the break in the continuity at the angle region suggestive of fracture. From the angle of the mandible, continue viewing anteriorly towards the symphysial region. Is there a history of trauma, and are there any discontinuities in the border? Is the width of the cortical bone at the inferior border of the mandible thicker than that seen on the posterior border of the ramus? It may be thinned by an expansile lesion like cyst, or may be thinned generally by a systemic disease like hyperparathyroidism. Here you can see there is thinning of the cortical border because of the expansile lesion like a cyst, or there is generalized thinning of the cortex because of systemic conditions like hyperparathyroidism. Continue viewing towards the opposite side of the mandible. Observe the mandibular outline, left mandibular angle, posterior border of ramus and condyle. Compare the outline of both the sides for symmetry, noting any changes if seen. Asymmetry may result from error in patient positioning. Asymmetry may also result from conditions like hemifacial hypertrophy or atrophy. Points to remember. The clinician should be able to follow a cortical border around the entire bone with the exception of the dentate areas. This border should be smooth without interruptions or step deformities and should have a symmetric thickness in comparable anatomic areas like angles, inferior border of the body of the mandible, posterior border of the ramus of the mandible. Next, assess the entire medullary bone of the mandible. Examine for expected structures such as mandibular canals, mental foramina, and various superimpositions frequently encountered. Examine the entire bone for radiolucencies, radioopacities, and in the peripheral central and periapical region. The midline is expected to be more opaque because of mental protuberance and superimposition of cervical spine. The region of submandibular gland fossa will be more radiolucent. Points to remember. Trabeculation is most evident within the alveolar process. Typically, the canals exhibit uniform width or gentle tapering from the mandibular foramina to the mental foramina. When only one border of the canal is seen, it is typically the inferior border. Slight widening at the point the canal bends to enter the body of the mandible from the ramus is a normal variation. Any bulging of the canal suggests a neural tumor. Now let us see how do we systematically interpret the OPG. So start from the superior aspect of the condyle, go down to the neck of the condyle, posterior border of the ramus, and see if there is any abnormalities. Go down to the ramus, angle of the mandible, and then the body of the mandible. Go along the lower border of the mandible and see if the cortical outline is intact. Then to the opposite side, angle of the mandible on the left side, to the condyle and to the mandibular notch, and then the coronoid process, and through the dentate areas, the interdental part. Observe the alveolar process, go along, and then the right side coronoid process, mandibular notch, and reach the condyle. Next, observe the medullary part of the body, the canal, the mental foramen on either side. See if the canal width is proper. Also check if there is any radiolucency or radio-opacity present along the medullary portion. Next part of OPG comprises of maxilla. So, examine the cortical outline of maxilla. Note the right side first and then compare with the left side. Trace the border of the maxilla beginning from the superior portion of the pterygomaxillary fissure down to the tuberosity region and around to the other side. So, always begin from the superior portion of the pterygomaxillary fissure down to the tuberosity region and around to other side. Examine the trabecular bone for evidence of abnormalities. It is very important to identify pterygomaxillary fissure on both the sides of the image because maxillary sinus mucoceles or carcinomas or leaf out fractures of maxilla will characteristically destroy the posterior maxillary border, which is then manifested as loss of integrity of pterygomaxillary fissure. So, it is important to identify pterygomaxillary fissure on both the sides. Here we can see there is fracture, and because of which there is loss of pterygomaxillary fissure. Examine both maxillary sinuses. Identify the borders, that is posterior, floor, anterior and roof. Then by noting whether they are entirely outlined with cortical bone, roughly symmetrical and comparable in radiographic density. Compare both the sides, but remember sinuses are frequently non-pathologically asymmetric relative to size, shape and presence and number of septae. So, right and left maxillary sinus are rarely symmetrical. The sinus is expected to be more opaque in the region of zygoma. Is there evidence of mucus retention cyst or mucoperiosteal thickening? Are there radio-opacities within either sinus? Are all the borders intact? These 4 things we need to see. Next, examine the nasal fossa. Observe the position of the nasal septum, then examine the orbit, observe the nasal concha, check whether the foreign bodies are there in the orbit, check whether floor of the orbit has any fracture. So, let us see the interpretation of maxillary part. So, this is the pterygomaxillary fissure. Try to trace the pterygomaxillary fissure and then the alveolar bone and go to the opposite side and trace the pterygomaxillary fissure. Next, trace the border of the maxillary sinus, the posterior wall, the floor, the anterior and the superior. Similarly, on the both the sides, try to trace the maxillary sinus and check if there is any radio opacity present. Next, trace the nasal fossa, trace the inferior turbinates, nasal septum and then the orbit and see if the structures are normal. Once we finish with the maxilla, next we have to assess the zygomatic bone. Assess the zygomatic process of maxilla arising over the maxillary first or second molar. Note if the inferior border of the zygomatic arch extending posteriorly from the inferior portion of the zygomatic process of maxilla to the articular eminence and glenoid fossa. Note the superior border of the zygomatic arch. The zygomatico-temporal suture seen in the middle third of the zygomatic arch, and it should not be confused with the fracture line. So here is the zygomatic bone, and this is the zygomatic arch, the inferior border. This is the suture, which should not be confused with the fracture line, and it goes on to the glenoid fossa. This is the superior border, and see if the zygomatic bone is intact. Next is TMJ. The TMJ can be assessed for gross anatomic changes of the condylar head and glenoid fossa. So check if the glenoid fossa and the condylar head is proper on both the sides of OPG. You have to check both the right and left side and see how is the condylar head and the glenoid fossa. Next, the dentition. Evaluate the teeth. Teeth should be evaluated for the number of teeth present. Check the stage of development, the position of the teeth. In the crown, check if there is caries or restoration, and in the roots, check the length of the roots, if there is any root filling present, if there is any internal or external resorption, and also check the crown and root ratio. Next, the apical tissues. Check the integrity of lamina dura, any radiolucencies or opacities associated with the apices. In the periodontal tissues, check the width of the periodontal ligament, the level and quality of crestal bone, any vertical or horizontal bone loss, any furcation involvement, and any calculus deposits. So, in evaluation of teeth, assess first the anterior teeth. Are both the incisal edges and root ends clearly visualized, or are they blurred from being positioned out of focal trough? Next, assess premolars, which are commonly overlapped on panoramic radiograph because of geometric orientation of X-ray beam. Are premolars on both the sides of equal dimension? Are they missing, fractured, grossly decayed, or do the premolars have single or multiple roots? These factors you need to check. Next, assess the molar teeth. Are contralateral maxillary and mandibular molars of equal dimension? Are any teeth unerupted, impacted, or missing? Are teeth supererupted? It's particularly important to examine impacted third molars closely. Check the orientation of the molars, the number and configuration of the roots, and relationship of the tooth components to critical anatomic structures such as mandibular canal, floor and posterior wall of the maxillary sinus, maxillary tuberosity, and adjacent teeth. The presence of abnormalities in the pericoronal and periradicular bone must be carefully studied. So, here you can see the orientation of impacted molar can be seen and how proximity it is to the structures like mandibular canal can also be seen. In children, check if all the permanent teeth are present and developing normally. Gross tooth changes, gross caries, large fractured or missing restoration, and large areas of pathosis can be visualized. So, in children, check the eruption status of the permanent teeth. Evaluate other regions in the radiograph, that is styloid process and calcifications. Styloid process usually appears below the mystoid process. Check the length of the styloid process and see if it is elongated. Also observe any pathosis like calcifications which can be seen. Here this is the calcification seen in the parotid duct which can be visualized in the radiograph. Suppose we see any intraosseous lesion during the interpretation of OPG. How do we go about? So, if there is an intraosseous lesion, first we need to localize the abnormality, check the periphery and shape, look at the internal structure and effect of this on the adjacent structures. So, in order to localize the abnormality, we need to study the location, number, size and position. The location can be unilateral like a dentigerous cyst, or bilateral as you see in Golling-Gauge syndrome, or generalized like florid osseous dysplasia. The number can be single as a single radicular cyst, or few or multiple. Size, please note down the size of the lesion. Position, it may be coronal to the tooth like dentigerous cyst, periapical like periapical cemental dysplasia, or interdental. It may be above the alveolar canal, it may be within the canal when it is more likely to be a vascular or neural tumor, or it may be below the inferior alveolar canal and less likely to be of odontogenic origin. It can be at the condyle, coronoid or antrum region if it is of cartilaginous origin. Next, check the periphery and shape. Periphery can be well defined or ill defined. Well defined can be of punched out border like multiple myeloma, or can be corticated as you see in the cyst, or may be sclerotic, or a radiolucent line around the radio opacity as you see in bone tumors. It can be ill defined, which may have a blending border as you see in fibrous dysplasia, or an invasive border as you see in malignancies. Shape can be circular as you see in cyst, or scalloped as you see in OKC, or irregular as you see in malignancies. Coming to the internal structure, it can be totally radiolucent like periapical cyst, totally radio-opaque like osteomas, or mixed radiolucent and radio-opaque structure. The mixed structure can be of orange peel or ground glass appearance as you see in fibrous dysplasia, or multilocular, which can be of curved coarse septa, soap bubble appearance seen in ameloblastoma, or wispy granular septa seen in central giant cell granuloma, or straight septa seen in odontogenic myxoma. Mixed lesion can also be because of calcification within the radiolucencies or tooth-like structure within radiolucencies. The last we have to see the effect of lesion on adjacent structures. The lesion can cause displacement of teeth, it can cause resorption of the teeth, it can cause widening of pedial space, there may be displacement or widening of the inferior alveolar canal, or there may be change in the periosteum like onion peel appearance. So these are the factors we need to look at when we see an intraosseous lesion. So intraosseous lesion, whenever we see, we need to see the site and localize the abnormality. We need to assess the periphery and shape, check the internal structure and also its effect on adjacent structures. You can sequence your evaluation in many ways. However, it is important to develop a consistent approach that ensures that all diagnostic information in the radiograph is indeed read. With this, we come to the end of this video. Thank you.